So then let's discuss the screening, isolation, and temporary holding, and then how we can notify the KCCA in this case. Yes, at your facility, we really want to see that all the people presenting to your facility have been screened properly using the standard case definition. That means that you are using the screening algorithm. And in that case, anyone who is identified should therefore be sent to a holding area. Again, there has been a definition. We have been redefining what a holding area should be and what a holding unit should be and what an isolation unit should be. I know you don't have the isolation unit. I know having a holding unit also is difficult, but in your small facility of 2 doors or two rooms, there should be a place where if a patient has met the case definition of Ebola, you can get a chair and sit that patient there, or you lie the patient just on a certain corner, and as you signal the KCCA. So we had been, this was not something which was agreed earlier, but we realized that small facilities cannot have what we want to be as a holding unit. So the definition of a holding area has just come on board of recent, but I know it will be reflected on the ODK, so that smaller facilities can have what we call a holding area, and that can be able to score that facility fairly well, because they can be able to identify, isolate that patient there, and then notify KCCA. So this is the minimum capability for all the facilities that they should have. For a higher level, of course, we want a holding unit, which unit should have a laminar flow. Staffs are going through this direction, then they come out through that direction. The equipment should be there in that holding area. A toilet for the patients, assigned for those who have been suspected. Different hand washing for them, which people are not sharing. So this is not possible for the lower levels. But where it can be, that is the minimum that we should have. Yeah. And so with that, we can now discuss about the screening. We are saying here that we do screening to recognize any suspected case as early as possible. And when we do, we now pick up that case and then put to a holding area in this case. Yes, where you have a seat somewhere, and you're holding your patient there. And so by doing so, you prevent community transmission, because the patient is not going back. Is going to be evacuated instead. You're going to help referral in that case for further management of that patient, and you'll be able to help that patient. And of course, you also prevent you yourself and your staffs from acquiring the infection in your facilities. So either it is you or your patients, and if the patient goes back also, they would also infect their family members. So the best that we can do, therefore, is to screen all the patients, isolate them, so that we call KCCA to refer, so that they can evacuate the patient and we improve the patient's survival. And while we do this, we make sure we do what we call a non-contact. You're not going to be contacting the patients because at the time of screening, you are screening while we will be discussing the 1 meter distance. And immediately when you identify that, you guide the patient to that. However, where it's not possible, you now look through and use an appropriate PPE, considering the risks, and then you help the patient as KCCA comes in to evacuate the patient. So the other discussion has been about screening and triage. So what are they and what is it? So we are saying screening here, we do it at the entry into the facility. Our interest is to identify individuals that meet the case definition for Ebola, and when we do, we can be able to send them to the holding area or holding unit, and it is based on the approved case definition from the Ministry of Health. So that screening algorithm is trying to picture the case definition for a suspect of Ebola according to the MOH. However, triage in your facility will mean that you're doing it at or during the admission or in OPD there in your admission time, where you prioritize all the patients, look through and recognize the ones who are critically ill so that you can rapidly help them and offer them an early intervention. And in doing so, you will be able to realize that, okay, this one actually also meets the case definition for Ebola, because we know Ebola also presents with quite a patients of Ebola can be quite morbid. So when you do your triad, you can be able to pick up people who are sick. It is from that list that you also can also be able to find that, okay, this one meets a case definition, and you can be able to send to the holding area. So this also helps the people who are in OPD or in the emergency unit, so that the time that this particular patient is in that unit is reduced. So triage and screening are very critical in our intervention. So we are seeing here, if by definition is a systematic process, that is screening, of rapidly evaluating the individual for risk of Ebola or a viral hemorrhagic fever in this case, including the others, using a set standard of questions to determine whether their illness should be investigated as a case of Ebola or not. So that's to do with screening. And the outcome of screening is to determine if the patient is suspected as having Ebola or not. So meanwhile, for triage, we are saying here that it involves assessment of the patient using validated tools to determine the severity of the illnesses. And we know from the EMS, we know that the different codes from the EMS and with different priority levels. And so we can be able to prioritize these patients and then be able to take appropriate action. In doing so, if the patient has Ebola, it will help us to minimize the time that the patient is there on that line. And of course, also minimize the duration of time spent before that patient gets a definitive treatment or help. Yeah. So in setting up a screening area, now this is not applicable for the small level facilities. I would wish to push it beyond. Okay, this can be at this is like for a bigger facility, but overall the general principle is that for your small facility, all you need to do therefore is to screen all your patients as they enter your facility. But most importantly, the screening has to be done in a non-touch, so you have a 1 meter distance between you and the people who are entering your facility. And so those who have been screened and the conclusion is that they don't meet the case definitions, they are the ones who go into your facility. Those who have been screened and they meet the case definition, you now send them to the holding area where you're going to signal the KCCA through the toll-free number, and then they can be able to respond. So this can be for a much bigger facility, but that's the general principle that you can have. This could be a simpler one where patients are coming up and there's that 1 meter distance and you can be able to screen them up. This also now is more applicable to your facility, in the lower facility where you can be able to screen them up. I think this is more applicable. Some facilities have this set up at their gates where they can be able to screen everyone entering. So there's hand washing, you can see there. So how should screening take place? That's the key question. We are saying screening is our main way of responding in terms of IPC, and how should it take place? So we have to screen all the patients entering the facility, and we do a non-touch. So we are not going to touch the patient and the visitors and all that. We do keep 1 meter distance all the time. While we do that, we need to let them know what we are doing. Otherwise, during this outbreak or any other outbreak, you want people to understand what you're doing so that they don't defy and try to dodge you and use some other gates to enter the hospital. So you have to explain the purpose of what you're doing and the outcome of what you're doing to them. So we're taking the temperature using the thermoflash, and you can see this picture. The person is pointing where I see Askari when they are doing the screening, they point wherever they want, sometimes on the arm, sometimes everywhere. So again, where do you point? That's number one. And then number two, is your thermoflash working well? So those are the key issues. So that when you get a temperature, you're getting a reliable temperature. After that, we record that temperature on the screening and the triage sheet, and continue with the assessment of symptoms. So we continue. That's the main word here. Taking a temperature is not screening for Ebola, but taking the temperature and getting a history from the patient is that what we are calling screening for Ebola. So in doing so, therefore, we refer to the screening algorithm to confirm if this person meets the case definition or not. So what is the case definition, therefore? Again, we have been redefining the case definition many times. There is almost version, I think, quite a version 4 something plus, as we have reached there now. This is simply because early in the outbreak, and then later on, things keep changing. You may realize that majority of your patients are presenting without bleeding or at all. So you need to be tallying up all your patients presenting that have been confirmed, and then you see which of these symptoms are really appearing most, so that you can keep redefining your case definition to suit the current event. Also, the context also matters a lot. We are saying in Uganda, quite a lot of febrile infection are there. So that means that your case definition cannot just have fever only. So for that matter, our case definition now here has fever or a history of fever plus any of the three of the following. So you find a list of the following. All the wet symptoms and the dry symptoms are here. So you need fever, which is not responding to treatment, or you need a history of fever plus this, any three of these. Then when you have that, you're saying, therefore, you have a case of suspected Ebola. So that now requires you to signal that case is here. Once again, I should repeat, this is the most important thing that we should be doing. We are saying that we should screen all the cases, and screening means we use the thermoflash plus the history. Once we have used the thermoflash, we come to the history here, which we are saying you should have fever or a history of fever if a person was not having temperature, high fever, but had it before, and then three of these: headache, vomiting, diarrhea, anorexia, lethargy, stomach pain, itching, muscles or joints, difficulty in swallowing, breathing difficulties, hiccups, and convulsions. So again, these words can be presented to you by the patient in a different way. So you need to therefore know the different ways people call some of these symptoms, so that you can say, okay, this is actually muscle ache that the person is meaning, for example. If that's not the case, the other option for case definition is illness with fever that has not responded to treatment, or a history of fever, because someone can have a history of high fever, and then by the time you're doing your temperature check, it is actually not febrile. She's not febrile. So again, that with at least one of the following. So you can see here now, the issues of bleeding, of hemorrhage comes up, bleeding generally. So if someone has fever that has not been responding to treatment, with bleeding from the os, there now you have what? Another a case of Ebola also. So that is very important. So they are saying here, fever and history of contact with a suspected, probable, or confirmed case. a history of travel to an area with the, okay, let's leave that. So the other third definition therefore is having a sudden or unexplained death. So again, in your clinic, a patient comes in and before you know, the patient has died. So again, for this purpose, you have to consider this as an Ebola case, a suspected Ebola case, and then also call KCCA to actually intervene. I'm sure for this, they will be, for all this, they will be very quick and be within your service to help you out through this. So the last one is unexplained bleeding. Someone is coming to you, fever is not there and all those is not there, but it tells you bleeding is, he never expected bleeding. There is no history of bleeding in the past, but now he's bleeding from the gums, he's bleeding from the eyes, for example, or from the ears, and there's no trauma or something. So if it is not explained, if the bleeding is not explained, please, that's also another case of a suspected case of Ebola. So you need to signal the system so that the appropriate action is taken. Yes, so the importance of screening, therefore, is that it plays a crucial role in stopping the spread of Ebola between the patient and the family, between the patient and the community, between the patient and the healthcare workers, so that they, within the facility that they are going to enter. So screening can prevent the introduction of Ebola into your facility. And it is important to keep healthcare workers safe and maintain the confidence of the health system and prevent the spread of Ebola in the community. Remember that for other Ebola outbreaks elsewhere, you find staffs are running away from the facilities because they have seen a very high infection rate among staffs, among healthcare workers. So the system will collapse. So what IPC does is to reinforce confidence in the system by ensuring that training is done, staff know what to do, they are confident, they know, they have the appropriate equipment for managing different situations. And we can see that the infections among the staffs are very few. For all this outbreak, all these interventions we have been having, we have had about 18 healthcare worker infections. And some of these are from small facilities. Some of these are in the early, most of these are early in the infections, in the outbreak. So later on, when the training and all that was done, staffs are more confident and the infection rates have been seen to be low. And that's why this screening is very important, or IPC in general is very important. So failure to recognize even one time or a case of Ebola, it will therefore enter your facility, spark infections in your facility, and go ahead to do the same into your community. So in that case, we're also discussing the importance of screening. It also gives you room to actually identify the patient, hold the patient in your holding area, in this case, or at a holding unit or at an isolation unit for higher level facilities, and appropriately inform the system so that the system can come and evacuate the patient. So the different screening tools now have been designed over time and reviewed, and the final one is this version 8. This is version 8 of the screening tool algorithm, where we recognize all the symptoms of Ebola: headache, vomiting, diarrhea, loss of appetite, lethargy, stomach pain, aching joints and aching muscles, difficulty in swallowing, difficulty in breathing, hiccups, and convulsions. These are the frequent symptoms that the patients have been having. And this, the epidemiologists keep adjusting this list as time goes on. When they hear something is frequent, they keep tallying up, and then they keep adjusting this. So at your gates or at your entry of the facility, you're going to do a temperature check for everyone and see, is this person having fever more than 38 degrees Celsius, or ask about the recent history of fever for all patients entering your facility. So you may do the temperature check and the person has this fever, high grade fever, or it tells you the fever was so bad in the morning, but it came in the afternoon, and it tells you it's a bit fair a bit. So that qualifies the person to have fever. And then therefore, if that is yes, so you're saying now, is this person having any of these 3 signs and symptoms at the side that we have listed? If so, then we suspect these patients, then we get KCCA number, and then we call KCCA so that they can be activated to follow up the case. That's the only thing we need from the lower facilities and also from the high level facilities. Again, if you do a temperature check at the gate and find this patient having 38 and above, and or having a history of a very high of fever, someone describing his fever very high grade and all that, if that answer is yes, and then is this patient having any of the following, just one of these following, a travel to Ebola affected districts, for example, Chegegwa, all that, Mubende, this is within the last 21 days. It's not the travel of more than 21 days. So within the last 21 days, if this person has had this travel, now that person also qualifies to be a suspect case for Ebola, and then you signal the system. The same when that person says he had contact with Ebola patients, whether that one was a dead, was alive, or a dead one, a corpse. So that again becomes a very, very important suspected case for Ebola. Just having fever and contact with a relative who has died, for example, and they know that it was Ebola. Also with bleeding. So if you have that high grade fever and then bleeding, if yes, then that's a suspected case. This bleeding is more pronounced on this third one here, where we're saying bleeding that is unexplained, regardless whether you have, so this is for those who don't have any of the fever now. So you've done your temperature check, the person is not febrile, there is no history of fever, but for patients who have had an unexplained bleeding from the ears, the nose, bleeding from the gums, PV, so, and is not expected, please, this is a suspect case, and then you activate the system so that the system can be able to respond. So overall, that is the key thing that we want you to do. And one might say, therefore, that, okay, there will be so many people reaching to KCCA, and it will be, in a day, there will be so many. It is not many. The KCCA alert management system has been designed to receive an endless amount of number of calls from different facilities. A patient can call, the relatives of the patient can call, healthcare facility can call, and you can call for different reasons. So for them, they can be able to categorize, this is a non-Ebola call, this is an Ebola call. If it is an Ebola call, is it for getting information about Ebola, or it is reporting a sign and symptom? So that one is categorized as a distress call. So distress calls can be managed effectively by the KCCA, as I will be showing in another slide later after this presentation. So and the KCCA expects, considering the number of population of people in Kampala metropolitan area, they expect 400 calls per day. In every 24 hours, KCCA expects 400 Ebola-related calls per every 24 hours. So that's the estimation by the WHO. So, and then therefore the screening outcome, at the end of the day, it is going to be 2 options. Either the patient has been categorized as a suspect, and then is informed of the outcome of this screening, and then sent to an isolation. In this case of yours, it will be a holding area where you have demarcated, where you can sit the patient and activate the KCCA call. Or a patient actually has no symptoms and is not a suspect generally, and has been sent to, allowed to enter the facility. So overall, those are the 2 key outcomes that eventually will come out from your screening. Additional consideration during screening: if a patient is unable to walk put on appropriate PPE, and assist the patient to isolate them. So this is very important. Sometimes the patient comes in and they cannot talk, they even collapse there, they're unconscious. So that happened in Mulago. So in that case, therefore, you do a risk assessment, get an appropriate PPE, and then be able to help the patient as you signal that KCCA. In the case of a child, one of the parents should always be present with the child. If the parent has no fever or symptoms, the healthcare worker will ask the parent to wear PPE before entering the unit, the isolation unit. In this case, a lower level facility, you are talking about the holding area. So where you can avoid contact with the child, for example, the mother has no symptoms, so you can put a PPE for the mother, and then the mother can hold the child as you screen and then appropriately signal the system so that they can respond. In a case of an adult, the accompanying person will not be able to stay with the patient. We are saying here, of course, that where you're holding the patient, we don't want relatives to be crowding and helping the patient by themselves. So the management of a suspected Ebola case does not require relatives to be helping the patient. And so what is the number of the KCCA toll-free number? And that is the number. If you call, I know there are very many toll-free numbers. For example, if you call the Ministry of Health using the toll-free number, they will still divert you and send you to this KCCA number, because we want to document every case, and a very good team has been designed and positioned at KCCA, the alert management systems, so that they can receive your call and appropriately help you out. So this is a toll-free number. You just need to dial it and you will not be taxed. Same to a text. You can send a text to this number and then they can be able to call you back. And so how to send and activate and alert them is you type here alert, and then the age, the sex, the condition of the suspect, the location, the district. But overall, if you have a phone, just signal the KCCA through a toll-free number. There is also 2 WhatsApp numbers I will share after if there's someone likes to WhatsApp the KCCA. So this is the entry point for all the interventions, the cascade of intervention that occur. Whether that patient is alive or is a corpse, someone has died just in your facility, that's the number for quick help. And so therefore, for your facility, we are asking holding area, isolation area, what is it in this case? So a lot of discussion has been done, and we are actually soon coming out with a more clearer definition that suits a lower level facility of like a small clinic. So what does it mean to be for a holding area if that person identifies a case? This is very important, because when we go to score your facility, you find that initially there was what we call the holding unit. You find that all your facilities don't have a holding unit, because we wanted to have a separate room where the patient, which is easy to recognize, away from the rest of the structures, with its own toilet, with its own hand washing facilities, and you can be able to do a one-way flow of movements, a laminar flow, where you enter in, work on the patient, and you move out, and you also have equipment in that place. So it is not applicable in this case, and a lot of this discussion has been done to try to narrow down what a holding area will be. So this is for a hospital. A hospital should have a holding area space to have at least 5 beds. So this is not applicable in your case. I'll just keep it up. However, there was a picture for a holding area, the final one that we agreed on, where there's a chair under a tree and no one is going there. So if you identify your case, you sit the patient there and you activate the KCCA number. The KCCA ambulance is not going to take off from KCCA, so that they take a lot of time. different ambulances have been positioned to different divisions. So in your division, they will just quickly respond. And different verification teams are also, and evacuation teams are already in the field. So you just activate, and then they'll be near you and picking up the patient. So this does not apply in this case. The PPE used equipments. So the screening issue is finished. So let's go to the PPE. So I'm saying here the PPE is least effective, is the least effective safety control. So I wanted you to remember that the inverted cone, where we had quite a lot of other interventions, including engineering controls, administrative controls, elimination. So the PPE is the last safety control that you have, and you should know how to use it effectively and even select it effectively. So its success is dependent, therefore, on the availability of an enabling environment that includes training, appropriate staff, staff of good cadre that can understand IPC and how to use this equipment, and then the guidance for appropriate risk assessment. The guidance, we have a job aid, which the ministry has shared, and I'll share at the end here, soft copies of them. And then proper PPE use in a motor skill. Use is a motor skill. You must do it to learn it. So it's like riding a bicycle. You cannot own a bicycle. You have the PPE and everything, and say, no, I have it, so everything is sorted. You must ride it so that you know how to use it. So again, from this training, maybe the UHF can organize maybe a hands-on training. Hands-on kind of exercise, so that people can dress the PPE and then that. But also, I know videos are there for PPE for Ebola, so that you can be able to view through the video. But it is something that you should first dress on, so that you appreciate. So safety considerations are there while using PPE. You don't touch your face while wearing PPE. So once you have, for example, been to the patient, so therefore your mucosa should be safe, and your hands to the face is something that you will not be able to do. Change PPE immediately if it becomes contaminated or damaged. So you have to choose the appropriate size of PPE for you, and then you choose all the required PPEs, also appropriateness of the PPE, and you use them. But once they get contaminated, like a patient has vomited on you, please, you terminate the process, you go and change up the PPE. So PPE should not be adjusted during the patient care. Once you have left the donning area and someone inspecting you has given you a green light to go, please go and work on the patient. But once something goes wrong and you find that there's an opening somewhere, you find that something is not convenient, you abandon the procedure, you come and you change your PPE. Don't go and adjust the PPE during your procedure when you have the patient there with you. Again, most of this is not for the facilities, because most of your patients are going to screen them, identify, put them to a holding area, and then you signal KCCA. It is only for patients who are actually needing emergency help at your facility, maybe they collapse or all that. That's when now you're going to put on your PPE and then be able to help the patient. But during that, you should know you are not going to adjust the PPE. If there is a concern or a breach of this, leave the patient. Okay, I've just talked about that. That is generally some other considerations for while using PPE. So the staff must undergo special training to ensure they can safely don and doff the PPE. So again, a video will be shared, but there should be a video where you can be able to try out and do some hands-on to dress and to dress on and dress off the PPE. So then therefore the risk assessment for the patient. In a situation where you find you are going to have a physical contact with the patient who is suspected to have Ebola, or you're going to have contact with their body fluids, or their clothing or objects that have been contaminated by their body fluids. So all this, you consider that's a category 4 risk. Therefore, you also put on a category 4 PPE, where you have the examination gloves, you double them. And these gloves, if you are a very tall person like me, there might be just above the wrist, there some space. So therefore, you need to consider that and put on appropriately. If needed, even you can put on the kind gloves so that it can be long enough to cover that risk. I know that some coveralls are short. Eye protection, the goggles and the face shields can be used, medical masks, coveralls or gown, disposable aprons, very important, and then gumboots. So these are dressings for category 4, a level of risk assessment, and appropriately you can be able to use that. I don't know if you will be having all this at your facility. That will be for the different partners to be able to provide them. But I know these items are being positioned in every division, so that quickly someone can be able to access them through the focal persons. I don't know if that mechanism works. So, and then for dead body and the management of for dead body management and cleaning or decontamination of surfaces, on top of the above, you use a heavy duty glove. So all these level 4 dressings, PPEs, you do them, but on top of that, get a heavy duty glove so that you can manage your dead body. Also for cleaning your surfaces in your unit where the case has been identified. Mixing disinfectant, the job aid is there, which we'll be sharing, and you can be able to mix clearly. But while doing so, you need gloves, respirator, apron, disposable gown, goggles, and face shield. So typically, that's what you may be needing when you're mixing your disinfectants. So the use of PPE in this green zone, because now you are going to zone your isolation unit or the holding unit. So outside the unit or in the green zone, in that case, you will be able to use just the scrubs and the gumboots in this case. This is also applicable, for example, in the Ebola treatment unit where there is a green zone proper, and people live freely. There's nothing else they're doing. But once they cross into the red zone, you cross with a proper PPE, which has been donned already, dressed on, and so you can see the level 4, the PPE for level 4 assessment. Once you score the risk as level 4, here is your PPE, and it's quite appropriate in this one here. So the different options are here, which you can have, but you can see typically the surgical gloves have been doubled, your apron is there, and then the mask is there, the face shield or the goggles are there, and the wood covers are there. Very important, the wood covers. It covers the neck and the shoulder. You can see coming up to the shoulder. And then, of course, the gumboots, the rubber boots, and the apron. So these are very good level 4 PPEs, which you need to have when you're helping an Ebola suspected Ebola case. So these are, of course, the different versions of it. They are not going to be seen here. So this is actually a pictures from the job aid, which I will be sharing. So it guides you on the steps of how to dress it. Step number 1, going down up to the last. Do this, do this, do this, do this. So those are the steps for. And there will be video that you can be able to click and watch for doffing and donning. So what PPE do I need for screening? So screening does not require any close or physical contact with the patient. We are saying you need to keep 1 meter distance. So it is recommended that screening is conducted using a non-touch technique. And when a no-touch technique or a distance of 1 meter cannot be maintained, okay, that's when now you need an additional PPE. Additional PPE is not recommended. Staff should wear a medical mask for COVID-19 protection and ensure an hygiene. So typically, you're going to keep a 1 meter distance and have a no-touch technique. And of course, taking into consideration COVID-19, you're going to appropriately put on your mask, and an hygiene station should be there so that you can be able to wash your hands each and every time. When a no-touch technique or a distance of 1 meter cannot be maintained, in this case, therefore, you advise the staff to wear an appropriate PPE and medical mask, therefore, eye protection, gown, and examination glove. So just that can be able to be used during the screening process at your entry or at the facility entry. So what PPE do I need for triage? We are saying that the critically ill patient, while they're there in your OPD, you need to do a triage for them. So remember, when you're doing a triage, the patient is very critically ill, and in the process of helping them, you may even be able to, they are fallen down, you want to put them on bed, you want to do what. So you may not avoid contact with the patient. So it requires a close contact or a physical contact with the patient. Triage can take place in different locations depending on facility size and the layout of the facility, and occurs at the point of screening, or the following PPE is recommended. If triage occurs at the point of screening, then the following is recommended, the same as the one above: medical gown, eye protection, medical mask, eye protection gown, and then examination gloves. You can see it at the side there. If it occurs within the isolation area, because there is primary screening and secondary screening, so if it occurs within the isolation area, now a separate screening, the following PPE will be required. So you can see an additional PPE. This is now a level 4 PPE is required. So you dress appropriately and do your triage. So here you're triaging from the isolation area where cases have been referred after screening from the gate, and they think someone is a suspect. But if you are screening from the triaging from OPD, again, this is appropriate for your, the one above here is appropriate for your screening. Yeah. So that was one of the key things about screening and all that which we have discussed. And I think we are coming to the last part, which is enhanced facility surveillance. I don't know if there is time. Maybe I get a feedback first before I proceed.
Oh, thank you, Doctor. I think I had seen some hands before. So as we have Doctor taking a sip of water, we can be able to put forward our comments or questions, so that or even our experiences. So just go ahead and unmute, or put up your hand, and then or even type in the chat, and we'll be able to respond to your question or comment. Any questions or comments? I'm sure there must be questions from what has been shared so far. Okay, maybe let me lead. You talked about the physical demonstration of donning and doffing of PPE, or the wearing and removal of PPE. In the WhatsApp groups that we've created, we'll be able to share some videos as well of what we're able to get and some messages, just to continue these discussions on IPC. And we very well know, yes, this is EVD, it's the tail end, but we know that we'll be able to also prepare for any other future outbreaks or pandemics that may come. So this is really an intervention to strengthen the system, but specifically the private sector. So members, are there any comments in the chat?
Ivan, I think as you get the comments from the chat, I'm not seeing any there, but maybe what we can do, I know Dr. Linda from WHO has just rejoined us, because I just admitted her, but as she joined and as we appreciate Dr. Mon for really a very detailed and very relevant presentation. I think as private facilities, one of the challenges is the training is usually tailored to big facilities, high volume facilities in urban centers. And yes, Kampala, all of the facilities on this call are in Kampala, which is an urban center, but they may not necessarily have all the infrastructure that the bigger facilities have. And I think it would be good for us to also share some information about from the findings of the assessments that led to this CME. Because I think Dr. Omon is one of the people that has been visiting facilities, doing assessments to determine the level of IPC and to inform the training that we're having today. So while people think of questions or even want to share experiences or even challenges, it would be good for us to pick out some of the areas that we saw as part of that assessment, Dr. Moni, for them to contextualize why it is these modules were designed this way, why we've covered this particular content. Because I know you mentioned private health sector health workers were being infected, and they were part and parcel of some of the directly affected in the initial days of this outbreak. So I think even from the participants or even from Dr. Mon himself, it would be good to hear, like Ivan is saying, your experiences, because from each other is when we can learn the most. Thank you. Over.
Thank you so much. I know Dr. Linda has been very active around Kawempe division. Maybe she can start by sharing her experience, but I have a lot of reports that I have been reporting daily to the National Case Management. So there are quite a lot of scorecard assessment summaries that can be reflected in terms of those scoring 80%, those scoring below 50, those scoring 50 to 79, and the reasons why they are scoring that. So it can be reflected, for example, ability to hold up a patient, a holding area, training of the healthcare workers, and quite a range of other activities, including screening of inpatients, screening in the inpatient wards, for which case for this level of care, you may not be having admission, or if you do, that's why we are discussing it next. So Linda, you could first come out. Or should I view the report at the end of the presentation, where we can see actually the summary of a scorecard, how it looks like, how it breaks different facilities into the different scores. But what I know is that when you go to score smaller facilities, you're going to find a lot of challenges. And one of those core ones is the IPC focal person or the IPC committee is not there, and yet our target is to see that for every facility there is a IPC focal person or a committee that actually is in charge to see that different healthcare workers within the facilities are well versed with the standard precautions, and they are adhering to it, and so that is number one. Then number two, I know that the capacity to screen at the gates, and then in IPD, for some facilities have been very down. For example, you find the thermoflash is not there. It's there only in the gate, and it is not there within the IPD. Or at the gate, you find that the SCARE is the one screening, and then they're just taking temperature. They're not doing the what? They are not doing the history taking. So that again cannot be able to identify a case and effectively link someone to KCCA case alert management. So that's one of those key things. And then also, once you identify a case from a lower level facility, one thing has been which makes people score badly, facilities score badly, is the capability or the ability to hold the patient. The holding area has been an issue of many discussions, like I said, but finally people are beginning to realize that a holding area now for a lower level facility should be a chair in a space that no one is going to reach, and then the patient can be sat there, and then KCCA is called. So that again will eventually come where now, when we are discussing or training for lower level facilities, you'll just see a chair in an isolated place where no one's going to go there, being a holding area. So as opposed to what was being scored, I know many facilities scored badly because the score of a holding area was very strict. And if you have one of the indicators missing, for example, if you don't have a toilet designed for the patient, or if you don't have a hand washing facility designed for that patient in the holding area, and that is unchecked, so you score badly on that. So those are one of the key critical things. But of course, also staff training. The question is asking, are all the staffs in your facility trained on Ebola IPC in the last 6 months? So if again not all the staffs are trained, you find that it will say no, and that means the facility scores badly. This is because they want everyone to practice the standard precautions, and also the transmission-based precautions. So they should know both the transmission-based precaution and also continue with what was being practiced daily on the daily. So those are the key areas that you find facilities score badly, which I can be able to project on the different slides, and also see the coverage of IPC in Kampala and all that. I have those reports here. So thank you so much.
So, Doctor, I think just in the chat, Mehdi says that with experience, screening should be confidential, as most clients in clinics don't want. It stops there, but I think they would want it to be in a private setting. But I think you had shared something more about the screening, really, where even temperature is taken before somebody accesses the clinic. But you can highlight more on that, and then maybe we'll call upon somebody from the MCHN activity. There's somebody who has written here through a private chat that some of them are unable to get the PPE. So is there a provision for that to get PPE? So I think that one will also be responded to. Over to you, Doctor.
Thank you so much. I will start with the screening. We have agreed very well that screening should be done at the entry to actually protect the healthcare workers within the facility, so not to allow a case of a suspected case of Ebola enter through into the facility. So that means, therefore, everyone before they access the facility should be screened. It is just the impression people have about screening. They think that you are going to identify a case of Ebola there, and then everyone will run away and start talking about them. So again, that brings up to one of those key points to note during screening, that you need to educate them, let them know why you're screening, why is it important for them and their families, and then the healthcare workers. So once that is done, you can be able to take, they are convenient with the screening and everyone screens, and effectively, if a case is identified, you send to the holding area. So you cannot allow the patient in the facility, find a place that is quite isolated, and then you screen the patient there. That's not possible. Screening also, there, when we go in detail, there are two kinds. There is primary screening and then secondary screening. So what we are talking here at the gates here is a primary screening, which can identify a suspected case and send to a holding area. Once that case is picked up and is sent by KCCA, they will again be screened thereafter. Or if it was a case that has been identified, let's say at Mulago, you find that there is a secondary screening place at the isolation unit, which they will again screen you through and categorize you appropriately. That's where now it can be a bit private. So this primary screening is at the gate, and there's no way of making it private, and it is very important. We can just inform them to let them know the value, the importance of it. Then regarding PPE, I know that PPE is being positioned to different divisions so that when there is need arising, they can quickly be utilized, both by the Ring IPC team and by the different teams that will be coming to respond. For a lower level facilities, it is not possible to really give PPE to the lower level facilities. I'm not sure if they can be able to give all of them, but I know some can be given. If for example, gloves, mask, I don't know the different partners if they can be able to do that, but it cannot go down to a coverall where it can be given. But pre-positioning these coveralls to nearby places around different divisions, so that when a case is identified, the people who come to help you when you signal the system are coming with the required PPE. That one is very functional. That one is already there in place. So thank you once more on that. If there are no questions, we can go to, we talked about screening in OPD. We may just briefly describe screening in IPD. I don't know whether this level of facilities are admitting patients. Otherwise, your patient at the gate might have no symptoms. They may not actually be categorized as a case of a suspected case of Ebola, but the day after in the ward, they can be evaluated, screened, and then you find that they meet the case definition. So that's the value of this discussion.